So once again, good evening all. We'll be having a brief session on septic shock today. I will be going through the slides slowly initially in the beginning. The final slides will be going very quickly. So today about the septic shock, we'll be talking mainly regarding the management of septic shock. The introduction, risk factor, etiology, pathophysiology, we will not be discussing about it today. We'll be only focusing on the management of septic shock. So by the definition of third international consensus definition for sepsis and septic shock, by definition, it's a life-threatening organ dysfunction caused by a dysregulated host response to infection. The definition of infection is any invasion of normally sterile tissue, like urine, CSF, or lung, by organisms resulting in infectious pathology. And organ dysfunction is increase of 2 or more points in SOFA score. The SOFA score, today we'll be discussing a little bit more on SOFA score. It's a sepsis related or a sequential organ failure assessment. This is very important on the initial assessment and on day 1 and day 2, following days, the SOFA score. So coming to the acute sepsis syndrome, it's a syndrome from mild infection to the most severe form, which is the septic shock. So initially, as you know, for example, it's a urinary tract infection. It starts from the infection and it goes to sepsis, severe sepsis, and septic shock. So it's a syndrome, it's a spectrum of disease from mild infection to the most severe form, life-threatening infection. And as per the sepsis definition, the SIAS criteria says the sepsis plus suspected infection. And sepsis 3 definition doesn't speak anything about severe sepsis. It just says sepsis and septic shock. So the discussion today is basically on septic shock. It's a sepsis and hypotension or vasopressor requirement despite fluid resuscitation, or increased lactic acid levels despite adequate fluid resuscitation. The lactic acid levels more than 2 millimole per liter. So this is a very busy slide. Please bear with me. I'll just explain to you the few basic things on this slide here. It's the SOFA scoring. The SOFA score is the sequential organ failure assessment, SOFA. It consists of 6 parameters. Number 1 is the PF ratio. It's the partial pressure of oxygen to the inspiratory oxygen. Normally, it's more than 500 milligrams of mercury at sea level. For a normal person, it's more than 500. The second is the coagulation profile, especially the platelet count. Number 3 is the liver function, specifically looking for the bilirubin. Number 4, hypotension or the mean arterial blood pressure. There is scoring given for each of the 6, the minimum score being 0 and the maximum score being 24. So the remaining 2, the CNS, the GCS scoring, and the renal function, which can be based on creatinine or the urine output. So just simplifying the SOFA and sepsis 3, infection plus the sepsis organ failure assessment consists of the 6 parameters: the PF ratio, hypotension or the mean arterial pressure, the platelet count, the drop in platelet count, the GCS scoring, CNS, liver function, which is basically the increased bilirubin, creatinine, or oliguria. So on initial assessment, it will help us prognosticate the patient based on the scoring. As you can see on the left side, if the SOFA score is less than between 0 to 6, the mortality is less than 10%. But as the SOFA score goes up, it becomes more than 90% if it is above 15. And on the right side, you can see the score trending. If the score trends during the hospitalization, if it is increasing, the mortality is 50%. If it is decreasing, the mortality is less than 30%. Coming to this definition of multi-organ dysfunction syndrome, it's a clinical syndrome characterized by development of progressive and potentially reversible physiological dysfunction. It's reversible physiological dysfunction in two or more organ systems, or it is induced by acute insults, any insult, including sepsis. The multi-organ failure is respiratory, cardiovascular, could be hematological, neurological, renal, gastrointestinal. So today's guidelines, what I'm presenting today, are based on the 2018 sepsis bundle of care by the European guidelines. It basically measures the recommendations are to assess the patient this surviving sepsis campaign bundle care at presentation, the zero time. It's the time of presentation defined as the time of triage at the emergency department. So when the patients arrive in the hospital, in the ER, then the time is time zero. And from there onwards, every hour is precious. So what are the things we need to do? We'll be doing on the first hour, second hour, and so on. So the first thing will be to assess the basic vital signs, see whether the patient is having sepsis, and if the patient fits into the septic shock picture, then get the appropriate blood test, including the blood cultures, start the antibiotics, and rapidly give the hydration, IV fluid boluses, and thereafter simultaneously start applying the vasopressors. So this is a brief picture where you can see the 5 stages at time zero. The time zero is the time of presentation of the patient to the emergency room, or from the emergency room to the ICU, wherever the patient is transferred. The patient might be in the general ward, and from the general ward, this patient is shifted to the ICU. That is when the time starts. So the first thing is to get some blood test, basic blood test, including a CBP, electrolytes, and here its focus is basically on measuring the serum lactate levels. Second point is to obtain the blood cultures before administering the antibiotics. It's very important to get the blood cultures before administering any antibiotics. If the patient is already on the antibiotics, say the patient was hospitalized and the patient was already on antibiotics, still at the time of septic shock, it's advised to get 2 blood cultures, 2 sets of blood culture, one from the peripheral line and one if the patient is having central line. Two sets of blood cultures, one from the peripheral and one if the patient has central line, or both from the peripheral. And then start the broad spectrum antibiotics. We'll speak about the antibiotics in later. Then start the rapid administration of fluids, intravenous fluids, which should be crystalloids. Normally we see the physicians are a little bit conservative when starting the fluids. They give one unit 500 ml of bolus, and then they start immediately with starting epinephrine or adrenaline. Here the emphasis on to give adequate amount of fluids before starting the vasopressors. So the final stage will be to start vasopressor if the hypertension does not resolve despite adequate fluid resuscitation. By blood pressure, it means the mean arterial pressure to be around 65 mm of mercury. So this slide was more important, so I have again summarized the points. Number 1, to measure serum lactate levels. Number 2, to get at least 2 sets of blood cultures, and then start the antibiotics. Number 3rd was to start a broad spectrum antibiotics depending on the patient's clinical scenario. If the patient is having respiratory sepsis, I mean, we need to identify the source of infection, whether it's respiratory, it's a GI or urinary. Depending on the source of infection, appropriate broad spectrum antibiotics need to be initiated. And number 4, administer IV fluids within the 3 hours of recognition. And final point will be the vasopressors, urgent restoration of adequate perfusion pressure to the vital organs. Vasopressor should not be delayed. There are 2 balancing point here. Start the IV fluids at the same time, and try to give enough fluids before starting vasopressor, but at the same time, vasopressor should not be delayed. So serum lactate levels, it's a sign of acute sepsis, but serum lactate levels actually may not be always because of hypovolemia. It can be also because of some other medical conditions like liver failure, some ischemia, and use of vasopressors. So the lactate levels are initially drawn on admission. That indicates most of the time it's sepsis, but always rule out the other causes of high serum lactate levels. So the initial resuscitation goals for the first 6 hours with IV fluid is to maintain the central venous pressure, so between 8 to 12, mostly between 10 to 12, and to increase the mean arterial pressure above 65, and the urine output to at least 30 ml per hour in a 60 to 70 kg person, and to increase the saturation, mean fraction saturation to close to 65. So how to check for the fluid responsiveness? We can do a bedside ultrasound to look at the inferior vena cava, IVC, or if you have a 2D echo, portable 2D echo initially, we can assess and see at least 15% increase in the cardiac output after giving 500 ml of bolus fluid challenge. But at the same time, we need to know that both CVP and pulmonary alveolar pressure have been shown to poor predictive value. They are not the best. CVP was very much in use until a few years. Since we started using the bedside ultrasound to look at the IVC, the use of CVP has decreased. So we look at the IVC diameter in inferior vena cava diameter and the collapsibility by the bedside ultrasound. But at the same time, we need to remember that IVC can be falsely dilated in certain conditions like right ventricular failure, pulmonary hypertension, cardiac tamponade, and it can also be falsely collapsed in increased intra-abdominal pressure, like in ascites or status asthmaticus. So coming to the second step, after drawing some of the basic blood test on initial assessment, then giving appropriate amount of IV fluids, then comes the appropriate empirical antibiotics. This should be started within the first hour of recognition of sepsis or a septic shock. Regimen should be reassessed daily for potential de-escalation. Procalcitonin levels can guide us to see if the patient, the empiric antibiotics to be continued or de-escalated. Always look for the combination empirical therapy in severe sepsis or neutropenic patients, and when you suspect multi-drug resistant bacterial pathogens. So severe infections associated with respiratory failure. Presently, we are dealing with the pandemic, COVID pandemic. Here, this is what we will be seeing: a respiratory failure and a septic shock. And this is most likely it's because of a hospital-acquired infection like Pseudomonas, where we use a extended beta-lactam along with the aminoglycoside and fluoroquinolone. And we are suspecting a community-acquired pneumonia like Streptococcus pneumoniae. The empiric antibiotics will be different, and the duration of antibiotic depends on the severity of the infection. So if the source of sepsis is from the lungs, pulmonary source, we'll be discussing mainly on the hospital-acquired pneumonia. So we'll be using anti-pseudomonal beta-lactamase, which are piperacillin tazobactam, fourth generation cephalosporin or carbapenem, along with plus aminoglycoside if the patient have a normal renal failure, and to add vancomycin or linezolid. Linezolid is contraindicated in patients who have thrombocytopenia. If the sepsis is thought to be from a catheter-related bloodstream infection, then the drug of choice will be to cover the gram positives with vancomycin or daptomycin. Along with that, an anti-pseudomonal beta-lactam like piperacillin or meropenem, or plus and minus aminoglycoside if it allows. And along with that, because most of the time the catheter-related bloodstream infection can be secondary to phengemia, it's recommended to start a fluconazole or echinocandin. And if you see, if we suspect the source of infection to be urinogenital, then a third generation cephalosporin will be enough, along with plus or minus aminoglycoside or a fluoroquinolone. So this is the most important point, is the source control. Unless we don't know, if we cannot identify the source of the infection will be ongoing. The source of infection has to be eradicated, to be first identified and eradicated as early as possible in first 12 hours. If the source of infection is most likely a central line, those lines have to be replaced. Coming to the fluid therapy, the fluid of choice is always normal saline to resuscitate. Give as much as possible in the first 1 hour. Try to pump up the volume to make sure there is no intravascular fluid depletion. The goal is to reach the mean arterial pressure above 60-65 mm of Hg, or a systolic blood pressure of more than 90 at least. Albumin is reserved only for refractive shock. Please do not use albumin for initial fluid resuscitation. And if despite giving fluids and vasopressors like norepinephrine, epinephrine, in the refractive cases, albumin is used. This is a very busy slide. I'll skip to the next one. Coming to the ionotropes, the last point is to start the ionotropes after or during the fluid resuscitation. The drug of choice will be norepinephrine, noradrenaline. Is the drug of choice even in COVID patients. It has very few relative contraindications. Almost in all patients, norepinephrine is the drug of choice. Thereafter, the second drug is adrenaline. Despite being on epinephrine and adrenaline, if the blood pressure is still low, the second line of drug will be vasopressin. And remember, low dose vasopressin, which was used earlier, is not recommended anymore. Start with high dose, 0.03 units to 0.04 units per minute. To be added to norepinephrine with the intent of raising the mean arterial pressure and to decrease the noradrenal load. It's a salvage therapy. It's not the primary. Coming to the favorite, dopamine. Dopamine is not the drug of choice here again. It's alternative to norepinephrine in selected patients, like patients who have low risk of tachycardia and who have relative bradycardia. Means like you expect the patient to have a heart rate of 120 despite having high-grade fever. Still the patient have a heart rate of 80. So despite having high-grade fever 104 and despite having hypotension, the blood pressure is heart rate is 80, which is normal, but it's having a relative bradycardia here. Coming to the phenylephrine, it is the last resort. It's again a salvage drug. It is recommended in patients who could not tolerate epinephrine. This is only to be started after the patient receives adequate amount of fluids. It should be started after the patient becomes at least euvolumic. And the last but not the least, dobutamine, which is something used specifically in patients who have myocardial dysfunction. As we see, patients with severe COVID are having cardiomyopathy. This drug can be used once the elevated cardiac filling pressures detected, a low cardiac output, despite giving adequate hydration and epinephrine. The other supportive therapy is to prevent infection, secondary hospital-acquired infection. For that, we need to limit patient contact. Even the nursing staff and other hospital people should have the limited contact with the patient. More focus should be done on hand washing. Day one, we discussed thoroughly about hand washing and precautions to prevent hospital-acquired infection. So an infection control team should be on top of this to prevent any further infection to the patient and prevent ventilator-associated pneumonia (VAP) by proper position and using chlorhexidine mouthwashes to prevent staph infection, MRSA infection. And the second supportive therapy is the blood products. In case of patient having severe anemia to transfuse RBC only in case hemoglobin is less than 7 grams, and not to use any erythropoietin or antithrombin agents. And FFP, fresh frozen plasma, not to be used unless the patient is bleeding actively, or if there is a plan of if there is a plan for invasive procedure. Dr. Junaid has already talked about this mechanical ventilation of sepsis-induced ARDS yesterday. Here, I'll just briefly discuss the target volume in the initial sepsis in COVID patient will be to give the normal tidal volume of 8 ml per kg, and thereafter in severe sepsis to decrease the tidal volume to 4 to 6 ml per kg. And as usually precautions of head end of the bed to be elevated to prevent aspiration, plateau pressures to be kept less than 30, apply adequate PEEP initially with 7 to 10, and later on as the ARDS develop more and more can go up to maximum 15. And in severe hypoxemia, we can use a proning position if the PF ratio is less than 100, and do not use beta-2 agonist. There was a trial where the previously beta-2 agonist IV was used in ARDS patient, but it's not used anymore. And to avoid neuromuscular blocking agents initially within the first 48 hours, if the PF ratio is less than 150. And coming to the weaning protocol, if the first weaning protocol should be, the assessment should be, if the patient, the reason why the patient went into the failure, respiratory failure, has been resolved. The reason for the intubation was because of sepsis, multi-organ dysfunction. That has to resolve before the patient can be started on weaning protocol. And the patient has to be, the GCS should be above 10. It should be hemodynamically stable. All vital parameters should be stable. And the patient should be on minimal vasopressors, or typically off the vasopressors. And the patient should not have any new potential serious condition. And the FiO2 of the patient requirement should be less than 40%. Coming to the fourth point, glucose control, is continuing to monitor 2 consecutive blood sugars on admission. If the blood sugars are more than 180, start insulin dosing. Target to keep blood sugars less than 200. Initially, there was in 2000, before 2010, there were stringent guidelines to control the blood sugar to keep it below 130, but that has shown that it is counterproductive. So we'll not be strict. At the same time, we'll not be liberal to keep the blood sugars above 250. And continue glucose monitoring every 1 hour, 1 to 2 hours while the patient is in the ICU, at least until the 4 consecutive blood sugars are normal. Coming to the bicarbonate therapy, it is not used routinely. Bicarbonate should never be used routinely initially, especially if the pH is more than 7.1, and should be used only after calculating deficit. Bicarbonate therapy has been shown to cause acute kidney injury and other problems. So, despite having renal injury, sometimes bicarbonate is given injudiciously, and it should be given slowly over time, should not be corrected immediately. The few points about the DVD prophylaxis and the stress ulcer, GI prophylaxis, use low molecular weight heparin and proton pump inhibitor for the prophylaxis of DVT, and intermittent compression devices like leg stockings.
You have 5 minutes left.
Coming to the nutrition, the address goal of care as early as possible. Within the first 72 hours, it should be started. Nutrition is important for the patient, even if the patient is on ventilator. The patient, remember, is in a catabolic state. He needs some calories. Start with the low dose calories. Try to use the gut. Try to use the gut as immediately as possible with low dose feeding up to 500 calories in the first week, and advance the calories intake as tolerated. The patient needs to be checked for any residual volume, and use glucose and the internal nutrition before starting TPN. Do not start total parenteral nutrition in the first week. So by this, I come to conclusion. Conclude. I have taken the following above information from this 2018 guidelines given by the Surviving Sepsis campaign. Just the last slide here. The Surviving Sepsis for guidelines for 2020, which specifically focuses on COVID-19. They have issued 54 statements, of which 4 are the best practice statements, 9 have strong recommendations, 35 are weak. The topics were infection control, laboratory diagnosis, and how to do the hemodynamic support, ventilatory support, and specific COVID-19 therapy. Inshallah, Dr. Yadullah will be speaking on the guidance regarding the sepsis campaign for COVID-19. Thank you.
Thank you, Dr. Parvez. Thanks for simplifying such a important, complex topic of sepsis care bundle. There's so many components in it, and you've done an excellent job in teasing out and simplifying it and breaking into smaller sections. And I've learned quite a few things myself. I need to make sure that next time I hear sofa, I need to think about sepsis, not the sofa in the house. And also you have simplified on use of vasopressors and indication of and superiority of non-epinephrine over the remaining vasopressors. Moving forward, I want to introduce our next speaker, Dr. Syed Yadullah, a shining beacon from Deccan Medical College. He is a trained nephrologist, intensivist, acute medicine specialist. Oh my God, he wears so many hats at one time. I don't know how he managed to do that. And it's an honor to have him on the panel as a speaker. He's currently working in National Guard Health Affairs, which is one of the premier institutes in the Kingdom of Saudi Arabia. Previously, he was working in Guy's and Thomas, where he trained most of his integrated critical care medicine training. He's also trained in Ecmo. He's written papers. He's a part and parcel of formulating guidelines. I presume he's also involved in formulating COVID guidelines for intensive care in Saudi Arabia. And he's taken his precious time out to be with us and share his experience with us. Dr. Yadullah, welcome to the panel.
So the topics that I was going to speak on was respiratory failure and guidelines for the management of COVID. The guidelines for management of COVID has been given by different organizations. One is a combined guideline by Society of Critical Care Medicine, which the United States follows, European Society of Intensive Care Medicine, the guidelines by NHS, and then you've got Australia and New Zealand Society giving guidelines. So what I've done is the SCCM and ESICM guidelines have got a PowerPoint presentation in terms of what they want you to do and what they don't want you to do. And I have uploaded that. I'm not going to be going through that. People can go onto their website and listen to the whole talk. But we are, as a whole, as an intensive care society, a combination of experts, they have got differences in opinion, and some of them are following and some of them are not. So I'll give you what my take is on those guidelines, what we should be doing, we shouldn't be doing, what we should be careful about. So I have clubbed these two presentations into one presentation. I understand that there are a lot of medical students as well in here. So I'm going to start from basics and then evolve on. I'm going to talk initially about how we collect evidence, how we evaluate evidence, and what we should be careful about in the current pandemic situation, and how we can deliver best as a community, society of doctors. And then I'm going to talk to you about respiratory failure. What does it mean by gas exchange? Why is oxygen important? What happens in terms when people get ARDS in COVID-19? How to deal with respiratory failure in ARDS in COVID-19. I'm going to touch on various ventilatory strategies, one that is followed by Mass General in States and one that's followed by GSTT, the European as well as American of dealing with it. Cursory, I can talk on a whole 45 minutes, but that's not the intent, and it's not going to pass on benefit. So I'm going to elaborate only on the things that are going to be asked back to me. Otherwise, I will give a run through of various treatment strategies in management of ARDS. I'm going to briefly be touching upon AKI, stroke, and also be touching on hemodynamic monitoring. what we do here, what we do in UK, and from there on. Let me start my talk. Okay, so what we do is that we have got opinion of experts. When you see something, you form a hypothesis and then you write an opinion. That's happening quite a lot. The classic example of this and doing some case studies is by Gattinoni, where he described the L type and H phenotype in ARDS. I'll elucidate that in detail as we come to further slides. Then we have got single center studies, then you have got multi-center studies in an homogeneous and heterogeneous population, and then you've got randomized control trials, and then you can do meta-analysis. And there's a group of experts who sit down and go through this meta-analysis in detail, dissect it, and find what's the best and what's the most cost-effective way, and then come up with guidelines to help deal with and deliver care of the patient. And the person, the physician who is delivering...
Sorry, Dr. Yadullah, can I just interrupt you for a second? Are you sharing your screen?
Yes.
Yeah.
No, not yet. We need to, can I request you to share your screen, please? We can't see any of the slides. Dr. Tawkhir, can you help him out, please? You need to press the green button and in front of you, share screen.
It says host disabled participant screen sharing.
Okay, sorry. So let me just reclaim host. Tawkhir.
You were under the impression that things are moving.
No, they are not. So why can't you share your screen?
Because there are two people, right, sir, with the same name.
Yeah.
So that's why it may be.
Maybe Tawkhir, you have one of you have to log off, please.
Okay, I'm leaving. I'm leaving.
Which one are you? I mean, this one. There are two Tawkhir. The one with the space in between, or the one with the. So I think So if you can log off the one you're logged in.
I've left.
Excellent. Very good. Okay. So can you help out Dr. Yadullah to share his screen, please?
Yeah, just a second. Yeah, are we on?
Excellent. Yes.
Okay, so now it's not moving. Yep, go ahead.
Okay.
Yeah.
Okay, start. This is the motto of why we are all here. We believe in saving lives, and I come from the concept that if you've saved a life, as if you saved the whole of mankind. And coming back to the way the evidence-based medicine is practiced, is we collect evidence, dissect it, then the doctors take the best evidence, takes patient values, discuss it with the patients, come to a common consensus and deliver care. Now, it's stuck.
Press the arrow button, it will move on. That's it. Yeah.
Okay.
Yes, it's good.
So what we do is, most of the studies are done in a group in this population, and they come up with conflicting results. We have done lots of studies, the results of which have not been replicated in the past. One study gave positive results, the other study came out with negative results. Now, there has been a drive in intensive care society to design studies in such a way so that we can address a subset of population suffering with a problem, how to treat them, and then further analyze the data and see if we can personalize the care to that patient. Now, for example, there have been studies in the past which suggested that certain patients benefit from steroids when given a sepsis, and certain patients do very badly. Certain patients benefit from angiotensin II receptor agents, whereas some don't. What is the reason for that? There have been development of bedside genetic testing, which may become available in future, currently not available, but that may tell which subset of population is going to be beneficial and which is not. We haven't reached to that stage. We're on its way. We thought that the fact that we have got big data, we have got internet, we have got good communication, we're going to use it. What has happened in this pandemic is that people has used WhatsApp more than anything else. They have read a lot of rubbish stuff. They have disseminated a lot of rubbish stuff without actually evaluating, reading it. So there is information there which is false and which is not helpful. And what has added to the problem that we are facing now is that big journals have published, reputed journals have published certain studies which would have gone into dustbin, absolute trash. And some of them have been retracted back. So there is a rat race to see who can bring out information first. They're not bothered whether this is correct or wrong, whether it's going to be benefit or not, but who comes in early rather than what's good and what can make it change. Luckily, there are certain egalitarian systems still running in the world, like NHS system, where there is no money involved. And people have been randomized there into various trials and got medicines, and all the data is collected, and ICNAR collect data from all the intensive care, and it is centralized. So they have got a real-time analysis of what was going on, and we got a good study out. There are certain, it still needs to be peer-reviewed, but it gave some guidance and some help and didn't waste money. Now, if you look at pre-pandemic, it used to take a lot of time to publish a study, but now the time from the time an article or study has been sent to the time of publication has come down dramatically. So it has brought down the quality of publications pretty low down. So how to address this problem? What bigger organizations have done? For example, Mass General, what has done in America, and big centers, what they have done is they are reviewing all the data that is coming in, some sensible person who is an expert, and then disseminating information, what should be taken from that and what should not be taken from that. Now, there are reasons which has driven this. People are anxious to know about COVID, how to prevent it, what therapies are there, and what can make it better, and how it can be cured. Now, there is an attempt from the medical community to come up with good stuff, but there is also an attempt of CV building and just doing things for the sake of doing it. So you have to be careful when you evaluate data. If you take garbage, garbage is of no use. So there have been wrong methods, wrong analysis, wrong conclusions, and there are numerous examples that I can give. Remdesivir got FDA approval just by one randomized control trial, which can be shredded if you do a critical analysis of it. Now, there has been a lot of drive from the companies who are trying to make huge amount of money from this. So you have to be cautious and careful. Is this really worth the amount of money? People are losing jobs. They don't have means of livelihood. They are going to spend a lot. They're going to be left without jobs. So we have to do only the things that pass on benefit. We have accountability as a medical community, and we should deliver. We should only do things which we feel are definitely going to pass on benefit, not hodgepodge treatments that has got doubtful evidence. Now, at times, this is very difficult. At times, you're treating the patient's anxiety or family's anxiety or yours, but there needs to be communication. And this can be challenging in a pandemic where you are stretched and running like a headless chicken. The one thing that I learned in medicine was this prayer when I went to do medicine. This is Hutchinson's textbook, clinical examination books, where he said, from inability to let well alone, from too much zeal for the new and contempt for what is old, and from putting knowledge before wisdom, science before art, and cleverness before common sense, and treating patients as cases, making cure of the disease more grievous than endurance of the same. Good Lord, deliver us. This fits perfect for this pandemic. Now, coming to the main topic of respiratory failure, why do we need oxygen? To buy anything, you need currency, okay? Dollar is worth more than a rupee. Pound is worth more than a dollar. So you would want to go for a pound rather than a rupee. So what happens? You take in oxygen, goes into the alveoli, and from the alveoli, it goes through the alveolar and blood interface, which is called interstitium, and then goes into the blood. From the blood, the red cells carry it to the tissues, and tissues uptake the oxygen. When the tissues uptake the oxygen, it goes into the cell. And why do we need that? So we need that because when we do, when there is aerobic metabolism, you produce much more ATPs, 32 to 36 compared to 2 in anaerobic. And these ATPs are needed to run all the pumps and maintain homeostasis in the cell, maintaining pH, maintaining the normal regulation, helping in the production of proteins and all the mechanisms that go around. If it's not there, cells get destroyed, lyse, release this stuff outside, which creates a myriad of reactions, which leads to an inflammatory or SIRS-like response. Now, when you inhale an oxygen, the first goes into the alveoli. For it to go into the blood, the alveolar oxygen concentration needs to be higher than what is there in the mixed venous blood. Then only it's going to go. The reason I'm elucidating this point is that first of all, the alveoli needs to be ventilated. So for that to enter into alveoli, you need to have the alveoli open, okay? There are mechanisms in respiratory failure where this concept is useful, so you need to understand this. Second, you need these alveoli to be perfused. If they are not perfused, if there is a mismatch between ventilation and perfusion, then the blood is not going to get oxygenated. So this unit is at fault if that's what happens. Now, if you look at this slide, it gives you an idea of what the arterial oxygen concentration and CO2 concentration is and where the split happens. It's too complicated, so I'll just skip and put it into simple words. There is an oxygen content in the blood and there is an oxygen delivery. There is a formula to calculate how the oxygen is delivered depending on the ideal body weight, which is called as DO2I, or the oxygen delivery index, which is 1.34 into hemoglobin into SaO2 into 0.3 into PO2. So don't remember this formula. What I want to say is that what are the things that dictate oxygen delivery to the tissue? One is the cardiac index. That means the cardiac stroke volume into heart rate that has been corrected for body weight. Then there is a constant, and the second is the hemoglobin in the blood. And the third is the PaO2, partial arterial oxygen concentration. So the three dynamics that are needed for carrying this oxygen, which will go to the cell and make the generation of currency. And there need to be uptake of this oxygen by the cell and use it. Now, the first description of ARDS was presumed to be by the person who invented the stethoscope, a historical fact. Now, type of respiratory failure. People normally consider only two types of respiratory failure. There are actually 4 types of respiratory failure. Type 1, 3, and 4 are hypoxic respiratory failures. Type 2 is hypercapnic respiratory failure. Now, what happens is that the PaO2 is low in all the 4 types of respiratory failure. The only difference is PCO2 is raised in type 2 respiratory failure. This happens when there is a problem with the chest wall or the central respiratory center is not keeping up enough drive and there's a retention. And classically, you see this type of picture in patients who have got exacerbation of COPDs, failing asthmatics, and patients with CCF. Type 3 respiratory failure is seen when the FRC, functional residual capacity of the lung, is reduced. If a part of the lung is collapsed, atelectasis, for example, post-operatively, the bases of the lung are atelectating, abdominal surgery, the patient, because of pain, doesn't breathe, just do shallow breathing, so the part of the lung is collapsed, so the FRC is reduced, that is the reason why they need some oxygen after surgery. Now, type 4 respiratory failure, interestingly, is when the perfusion is decreased to the lungs. Now, this can be due to lots of reasons. When there is a huge amount of respiratory drive, the oxygen consumption by the respiratory muscle can go up to 10-folds. There can be decrease in the coronary perfusion. There can be decrease in the cardiac, especially the right side that decreases the perfusion. Sometimes in ARDS, we try to run the patients negative. If you run them too negative and decrease the right heart output that is going to the lungs, that will contribute to hypoxia. So you have to be careful about the fact that you're not running them too negative, you're just running them slightly negative. So that can lead to type 4 respiratory failure. ARDS definition this is the Berlin definition that we normally follow. Now the timing is within 1 week of clinical insults, and there is bilateral opacity, there's no pulmonary edema, and it's described as mild, moderate, severe. I'm pretty sure you all know this definition. Severe is when it's less than 100 PA to FiO2 ratio. Between 100 and 200 is moderate, and greater than 200 is mild. So we are interested in the severe and the moderate group here, not the mild group. Now, does COVID-19 pneumonia, what's called as NCP or novel coronavirus pneumonia, cause that is does it fit to the definition of ARDS? Now, we have seen 3 patterns in COVID-19 pneumonia where the patient comes morning, he got unwell. By evening, he's so unwell, he's coming on to ER and you're tubing him straight away. Crashing and burning. That's simple. That fits into the ARDS definition. And these are the H phenotypes which I'll describe later. Now, there are some L phenotypes that come in where the patient is on oxygen, goes to the ward, has optiflow, it goes on for a week, and it grumbles along. This is not falling in 1 week. And either they get better or they crash and burn, go on to NIV, get intubated and come on to ICU. This doesn't behave the way the classical pneumonias or infection with H1N1 and other SARS or MERS-CoV has behaved.
Sir, you have 5 minutes left.
No, let him carry on.
Okay.
So two combined together. So the common causes that we see in ARDS, in West we see a lot of ARDS. Now, and there are highly specialized centers that deal with ARDS. I was privileged to go and see how they manage ARDS when I did ESIC fellowship in Italy, and I've seen it in UK centers and in Ecmo centers. Now, the commonest reason that you get ARDS is because of pneumonia. The second is sepsis, okay? Most of the patients with sepsis, especially elderly with comorbidities, go on and have developed ARDS. The surgical cause that I've come across is pancreatitis. The third is the drug overdose. Other causes are less common, but maybe more common in other prevalent areas in the world. Here we'll be just concentrating on ARDS caused by COVID and will not be concentrating much on the other varieties of ARDS. I will touch base on pneumonia because there are going to be secondary bacterial infection and fungal infections in patients with COVID-19. So if you see what happens in ARDS, it goes through 3 phases histologically. This is, you don't need to know in detail, just to give you a flavor so that you know clinically how they are behaving and what therapies we can use to help and negate the effect of these. Now, first is an exudative phase. What happens is that left side of the diagram shows that this healthy tissues, intact endothelium, good interface, oxygen percolating into the blood side, and red cells happily taking the oxygen and going to wherever they want to go. On the right side, you have got an insult. Let's say for the sake of discussion, COVID-19 goes and launches an immune response. The white cell comes in or gets angry, now releases lots and lots of stuff in the form of leukotrienes, cytokines, interleukins, causes a lot of damage to type 2 pneumocytes and type 1 pneumocytes. There is secretion of proteins. So the interface is interrupted here and there is damage to the alveolar membrane and the interface. And when these toxins go in there, as you can see in the blood vessels, they are prothrombotic. Now this is a pro pathway that I'm seeing, showing. I won't go through the detail. The nutshell is these pro-inflammatory cytokines causes infective endothelitis and give rise to microthrombi. So certain centers like Mass General are recommending to give statins until the patient is discharged from the hospitals if there are no contraindications to help with endothelial stabilization. Now, coming to the exudative phase, it goes on, the edema is there, the edema phase is for 1 to 2 days, then for first week you have got exudative phase that moves on to proliferative phase, and things may go towards worst in severe ARDS and goes to fibrotic phase. That's when the horse has left the bolt. The first 2 areas are the one where you can give therapies and can modify the response and make things better. It's difficult when it reaches the fibrotic phase and it becomes much more challenging. This is the slide of a proliferative phase histologically. Now, what it means clinically. Clinically, there is a lung injury. There is a damage to the alveolar wall, which is our gas exchanging unit. So the PaO2, alveolar oxygen concentration, is going to be decreasing because there's injury in there. So whatever FiO2 is going is not going to be the same as the PaO2. Now, when there is damage to the interface, this is not going to diffuse into the cells. And in the blood circulation, either they are clogged or they have got wrong cells, not the red cell, but the white cell sitting in there. So there is a BQ mismatch as well happening. And because of the secretion, there may be collapse of that alveoli that decreases the FRC as well. So this all impairs the gas exchange. So this decreases the lung compliance. And when these substances are released, they can cause vasoconstriction in the pulmonary microvasculature. So when the bad part of the lung is having all these, there is a constriction. So what body is trying to do is to shunt that blood to the good part of the lung so that that gets oxygenated well. When that happens on a grand scale, there's a back pressure and gives rise to pulmonary hypertension, and it can give rise to acute right-sided heart failure, which can be a problem. Now, just to mention, the studies that we have seen that come out has shown that there is no greater incidence of right heart failure in NCP or COVID-associated ARDS compared to the other ARDS. Now, can this be classified as ARDS? So you get hypoxia because of dysregulation of pulmonary perforation and microthrombi. Now, this doesn't fit into the ARDS type picture. So there's low elastance, there is low VQ mismatch, there is low recruitability, and PEEP response is not there. If you give 8 ml per kg tidal volume, that's recommended in these patients. So you don't need to go low tidal volume in this, you can give high tidal volumes, but higher PEEPs are not needed in this. It may just unnecessarily give barotrauma. So this is the L phenotype that Gattinoni has described. A lot of people like it. I personally like it because it makes sense to me. The evidence, it needs to be further evaluated. Now, looking at the pulmonary edema type picture or the H phenotype picture, there is high elastance. You give higher PEEP, they recruit and oxygenation improves. There is a high right to left shunts, and there's a good PEEP response in there. Now, what happens in the initial phase of SARS-CoV is that there is an initial vasodilatation when there is an L phenotype. The L phenotype can progress and will normally progresses to the H phenotype if things don't get better. And when it goes to the H phenotype, there is vasoconstriction in there. Now, these are two images of the CT scans. One is a non-ventilated patient who is on non-rebreathing mask. The upper one, which is the L phenotype, you get black X-rays with very little consolidation. In the H phenotype, you get consolidated and whitish X-rays and white CTs with full-blown picture and poor oxygenation. The below one is intubated guy for the same fraction. Now, these again, the images upper one are for the L phenotype, below one are for the H phenotype. You can see more blackish looking picture upper and the more whitish looking picture, just as a gross scale to see. Now, can CT images be used to guide ventilatory strategies? The answer is, if you go by Gattinoni's theory of L and H phenotype, the answer is yes. If you've got an L phenotype, there is low elastance, low lung weight, and there is some ground loss densities of HRCs and low recruitability. So you can easily give 8 to 9 cc per kg of tidal volume. It wouldn't cause any problem, wouldn't damage, and you can give lower PEEP. If you look at the H phenotype, it has got a high elastance, high lung weight, and you see dense consolidation when you look at the CTs and high recruitability. So these are the ones you have to give less than 6 ml per kg of tidal volume. PEEP can be given high, maintain plateau pressures less than 30, ideally less than 28 or 24, and delta P, which is the difference between the PEEP and the plateau pressures less than 15. Now, looking at the compliance of these two types. Now, if you look at, I think I'll just skip this slide. Now, what does the Surviving Sepsis Campaign guidelines or SCCM or ESICM guidelines tell us? COVID-19 hypoxia. He has come, the poor guy has come from home. Now he's hypoxic, he's needing oxygen. So whenever they need oxygen, start them on oxygen, put them on 6 liters. Better to give non-humidified compared to humidified. May make the alveoli a bit crispy, but lesser dissemination of infection. Certain countries follow this, some don't. Follow infection control precautions very seriously and strictly. Now, what are the saturations, target saturations that you're going to be aiming for? Here it's written as 92 to 96. The lowest you can accept is 90, not below that. So 92 to 96 is what you're going to be accepting. Do not go for 100. Unnecessarily giving oxygen will cause free radical injury, okay? And if your oxygen requirements are going up and the patient is not tolerating and you're on 15 liters non-rebreathe or going towards a trajectory, there are two subsets. One is, which has got a more workup breathing, which is lesser workup breathing. So people who are very tachypnic, happy hypoxics, they feel, oh, doctor, I'm perfectly fine because the virus has got a neurotropic effect. They're unaware subjectively of their hypoxia. Whereas we are looking at them and they are chucking away at 50, 60 respiratory rate. They need tubing early. H phenotypes needs tubing early. If their respiratory rate is not ridiculously high, then those are the ones that you can trial on NIV. Now, high flow nasal cannula, consider with caution. I'll talk about it in more detail, and then a trial of NIV. Please, please, please wear personal protective equipments. This is very important so that you don't get infected. Now, there is the pandemic. I personally feel that the number is way higher because we have not tested numerous amount of people who are asymptomatic. One of the recent studies that have come out from the NHS is that maybe up to 80% of the people that they have been screening are coming back as asymptomatic COVID positives. So what we are seeing are the worst case scenarios of the patients. So asymptomatic patients can cross the infection to you. So be careful about it. And the fatality that you're seeing is probably you're calculating a bit higher because you don't know the denominator correctly. The more you test, the horrible it looks. So this is the GSTT way. So oxygen therapy, 90 to 94, FiO2 start at 0.4%. Make ceilings of care very early. What you're going to offer to that patient. This patient is for NIV. This patient is for not for NIV. This patient is for intubation. This patient would be for extracorporeal life support if needed. So make the decisions early, discuss with the family. That prevents from when the patient's crashing, that prevents from unnecessary treatments being given to you. So if the patient's work of breathing is low, that's only the time when you're going to be considering non-invasive ventilation. Now, depending on the respiratory type, there are a lot of factors that is. So if you allow this patient to chug away at 50, 60, what happens is that there is rapid swings of intrathoracic, intraesophageal pressures that leads to a lot of edema being forming there. Excuse me. That leads to patient-induced lung injury. So you have to be aware of this fact. And you have to support and assist it and decrease injury cost to the lung from this. As we talked about the hyperacute course, then the underlying course where there is improvement, they may go down, and or the biphasic course where it goes down and then goes up and the patient goes to ITU. Excuse me. So I'm not going to be reading through all these guidelines. There is a separate presentation where you can go through slides, which are about 80 slides, but I'm going to touch on some important, what we follow and what we don't follow and why we do that and what's the logic behind that. Now, there is best practice statements are regarding wearing N95 or fitted respiratory mask or FFP2 or equivalent. We follow that, we doff and down, we take extreme precautions, okay? People who don't have facilities to doffing downing, limited resources, gloves are must, you can wear pins, you can have a screen that is disposable one, or you can have a plastic one, you can clear and clean it and reuse it multiple number of times, like the people who are welders or carpenters or wood workers who have, you can flip it up and down. So that prevents from going into that cap and N95. Otherwise, doffing and downing is the ideal way forward. The second thing is patients who have got have COVID should be in a negative pressure room, preferably. Definitely all NIV patients and patients, if you're putting them on high flow oxygen, should be in a negative pressure room, okay? So this is very high, these are things which we follow. And if we are intubating, we intubate them in a negative pressure room. The number of people should be minimal. I'm going to touch with in the future slides, okay? Now, I must tell you that if you do a PCR, there's a 30% chance that the samples might be negative. We normally do two PCRs 12 hours apart and load on bronchial sample if we need to. Now, we talked about whether to maintain saturations at 9%, we maintain it a bit lower as well. Now, what happens is that when you're trying to maintain it a bit lower, they did a study, liberal versus conservative oxygen therapy, and they had to stop the study earlier because they found there was an increased mortality in conservative group. You have to be very careful. Now, organizations advise the use of high flow nasal oxygen, as it's called, is UK NHS doesn't recommend because of the risk of infection. WHO and Society of Medicine and Australia and New Zealand Society, they recommend it. but Australia and New Zealand said don't recommend NIV, whereas rest recommend NIV. Now, NIV can be used as a treatment. Now, there's a common teaching that we tell medical students or trainees is that if you have got pneumonia and is going to respiratory failure, don't put on CPAP, just tube them. Now, here, there is a slight difference in pathology. Some of them may get away by NIV. Now, there is a resource constraint as well. Putting them on NIV may buy the resources to allow them to get a ventilator. Or you can use it as a ceiling of care, but do not unnecessarily delay or prolong NIV where it is not indicated. Otherwise, the patient will crash when they are tubed, they will de-recruit, you'll have to pack them, you'll recruit them, prone them. It's a big headache. And you may lose the patient at times. So what are the recommended interfaces for using NIV? The full face one with the filter fitted is the one that's the first choice. Here, the picture doesn't show full face. It needs to be full face, but shows filter in there. Now, second choice is helmet with an air cushion for CPAP. Without air cushion is the third choice. And the standard full face mask is the fourth choice for your interface. Now, when to use that? Obviously, if somebody is getting tachypnic, the gases are bad, type 1 respiratory failure, desaturating, even despite being on high oxygen, the work of breathing high, you don't linger on NIV, okay? If the work of breathing is low, then you linger on NIV and give them a chance to see if they are stable on that, improving, or they are going downways. You tube them early. Now, there's a vicious cycle that's going on. There's an impaired gas exchange from lung edema and capillary leak, and that leads to impaired lung elastance, that leads to increased respiratory drive. The patient is breathing more because oxygenation is being impaired, and then that leads to patient injury, self-induced lung injury, PCLI. What the happy hypoxics are happy because they're still trying to maintain oxygen delivery. They're breathing quite a lot, work of breathing is quite a lot, but it's going to the tissues. The tissues are not hypoxic. Now, one thing you need to understand is that nobody dies of hypoxia. People die of multi-organ failure and the first response that happens. Hypoxia is a big driver in this process. So that's something that needs to be taken on board. Just correcting the number won't save the patient in the end. You need to treat the patient as a whole. Now, in ventilation, now what is recommended is that the saturation, so it's a strong recommendation, maintain saturations in between 92 to 96, 90 is acceptable, not below that. If somebody's COPD and advanced lung disease, really should they be intubated and ventilated in this pandemic is a question you really need to ponder. But if you end up with somebody like that who's very young, but you want to give a chance, 88 to 92 is fine in those. Otherwise, in other subsets, it's not. Now, other recommendations like high flow nasal cannula, NIV, I've just discussed to you about what we feel about it. And in terms of ventilatory strategies, for L phenotype, you can use a tidal volume of greater than 8 ml per kg, but for H phenotype, 4 to 8. Less than 6 is what is strongly recommended. Plateau pressures less than 30 is what's recommended. Ideal if you can get it less than 28, best with 24, but that's a dream. You will not be able to do that. Don't chase that. Less than 30 is okay. Driving pressures, that is the plateau minus P, less than 15. That's what you should be aiming for. These are strong recommendations. I'm not going to go through these weak recommendations. The slides are up for you to read up for them. Then there is a debate about the use of staircase recruitment maneuvers. Now, the guidelines recommend against this. But if you look at the Americans, they say, like Mass General, they wouldn't recommend going against. They like the staircase way of increment. It's an individual choice. If the patient's very dry, going on to very high PEEP suddenly will decrease the right ventricular output and can cause compromise. You can go for staircase in a certain cases, not in all cases. So it's what practice suits that patient best is what you have to pick. Patients have got good outcomes if they are appropriately selected for Ecmo, those they are failing all ventilatory strategies. But this is not the time to learn and start new centers on Ecmo. This should only be done in established Ecmo centers. And this is, we are talking about VV ECMO, not ECMO CPR. So you have to choose the right type of candidate. I'm going to talk to you in future slides. Now, invasive ventilation, when you're coming to tube the patient, this is so important. You see the picture there, that's how we doffen down. We decide before going in who is going to be doing the procedure. The most experienced person, the consultant or the senior staff physician or registrar, should be the one doing the procedure. What is their plan A? What is their plan B? What is their plan C? What drugs they're going to use? They should keep it ready. What individual roles the team members are going to play and who's going to be in and who's going to be out as a runner, that needs to be decided. We need to have a clear plan and who is going to do one-to-one communication. Because when you have got the tough and down with the air blowing in, it's very difficult to communicate and talk with your colleagues. So these things need to be decided well in advance. Take a gyroscope if you have got it, please. And if you have not got much experience of using gyroscope, better stay back and see the consultants doing that and then go on. Otherwise, you may struggle with gyroscope rather than laryngoscopes. These patients recruit pretty fast. You need to decrease the time for tubing. Unnecessary bagging is very bad. I would refrain from that. If somebody is de-recruiting and you had a look at the gyroscope and twice, just put an LMA, ventilate through LMA, recruit in, get in, then go in, use the bougie, have no shame in using adjuncts to have an easy intubation. Gyroscope use is highly recommended, and the most senior person should tube this. Now, people who don't have all the facilities, some of them in cases to prevent the aerosol spread, it's a good idea, but I don't have much results coming from big studies to say that. And after every endotracheal intubation, there should be a plan of immediately switching onto a ventilator with what settings you're going to do, what medications need to be done, should be kept ready as infusions, and there should be a debrief, not only if something wrong has happened, but if something good has happened, because there is a burnout among the medical staff and personnel. They should be complimented for the great work they're doing. So good work should be complimented, and there's something that we should bring differently, should be addressed to the team. Now, this is another intensive care society slide, which tells the same certain things. Avoid bagging, please. And if you've got an IGL and if you're struggling, just put it in there. And be ready if you can't see, and if you can't tube, if there's a difficult area, going through the DAS guidelines, be ready from front of neck airway. Keep it ready just to open and just crack on with it. Don't waste time. Now, in terms of mild ARDS, it's not much of a problem. You all know how to treat it. Now, coming to the starting of antibiotics, it depends on what the bugs are there in your area and what they are more susceptible to, which antibiotics. So you're going to be covering gram-positive, gram-negative, atypical bugs, and you'll be giving oseltamivir until the flu results come back. Then you're going to discontinue. If the atypical screen is negative, you're going to discontinue the atypical screen one as well. And you may just continue with whatever antibiotics. Now, there are studies, people like azithromycin. Be careful with the QTC if you like azithromycin liker, or the people may be going ceftriaxone, or in UK, just go for benzyl penicillin and clarithromycin. And if you're using clary again, look at the QTC. Now, coming to steroids, I'm going to talk about recovery trial. We'll discuss in a bit more detail. Then in moderate ARDS, you need to recruit the lungs. You need to open up those alveoli by giving in a PEEP, and especially in the H phenotype where high PEEP works. So staircase recruitment maneuvers, not recommended by CCM, but we do it. I haven't found it much different from the non-staircase where you're going for ridiculously high PEEPs for shorter duration of time. I'll tell you what the ventilatory strategies that Tommies do, which is much more amenable and which you can extrapolate in India. Now, neuromuscular blockers, if you sedate them, take control of the ventilation. Mandatory ventilation is inferior compared to patients spontaneously ventilating. But when you initially tube them, you need to sedate, take control of the ventilation. Only when they are improving, that's when you go on for the sedation or decrease the sedation twice a day to see if they can be switched on to CPAP pressure support, if they are not able or not. That doesn't happen in the first few days from my experience of having managed lots of these cases. So sedate them, and if you need to paralyze them, paralyze them. Okay? Then nitrous oxide and cloning, I'll talk to you later. Now, one of the things is that when the patients are on the ward in L phenotype, awake cloning does help in certain subset of patients, not all, who are not progressing to vagus, who are getting better, lying down for 8 hours and then flipping around. Now, you know about the saturations. This is the GSSTT protocol. And what the aim is such is 90 to 94. They're looking at 8 kPa. What they are also looking at is the 1 kPa 7.5 mmHg for those who want to extrapolate that. And plateau pressure less than 28, ideally less than 28, but less than 30 is fine. So what they're looking at when you put them on a ventilator, set up a PEEP of 8, there's an ArdsNet table, which you can Google and bring it up, depending on what their 502, what the PEEP should be, and depending on what the weight, what the PEEP should be. Mass General has gone in what the BMI is, and depending on that, they have set PEEPs for less than 30, 30 to 45, and greater than 45. Obviously, if you've got somebody who's got a BMI of 45 is super obese, they need high PEEPs like 15. Whereas people who are got less than 30 may need PEEP of 10 only. So if the driving pressure is greater than 15, then you go to tidal volume of 6 ml per kg. If they are less than 15, then you can go for higher tidal volume. Keep the patient neutral and slightly negative, please, okay?
There have been a few questions coming up from the attendees regarding when to start the steroids, why the pneumothorax is common in COVID patients. Can anyone answer these questions for us, for the audience, please? Why remdesivir is not the drug of choice anymore? I think Dr. Yadula has already addressed this question because this was a single randomized control trial regarding remdesivir.
There are quite a few slides, what is helpful and what's not helpful.
Yes.
And I'm going to address those questions. As far as the first question goes, why you get pneumothorax? Pneumothorax, you get it because you are using high PEEP. And if you're using high PEEP, it causes barotrauma. And you need to use adequate amount of PEEP. And that's why the role of H phenotype and L phenotype is important, especially if you are using it in L phenotype, you end up having lots of pneumothoraces. So it's very important to use optimal PEEP in these patients. Sometimes you will have to see what is the optimal PEEP for that particular patient by going on a high PEEP and slowly decrementing the PEEP, coming down on the PEEP and seeing at what point the saturation starts to come down, then go up slightly and then stay at that point. And despite doing that, sometimes you do end up having some pneumothorax. So that's something that you have to live with and keep a very close eye on for that one and put in chest drain.
I have one question regarding the happy hypoxics. Correct me if I'm wrong. I think these people are like, they're like standing at the edge of the mountain. They are exhausting their capacity and they just crash very, very quickly, if I'm not wrong.
Yeah. Now, what I've seen is that there are two things. Not only the patient is hypoxic, the patient is unaware subjectively that he is hypoxic. You do again, the PO2 is 50 mmHg. But there is also a sort of look on the staff face, especially in the initial phase. Like, okay, he's doing all right, he's managing. No, he's not managing. Look at his gas.
He's exhausting all his resources, yes.
You need to be not reassured by the fact that when you go to the patient, he's saying that, no, the doctor, I'm fine. No, you are not fine. These are the parameters. You need to be intubated. You need to tube the patient.
I think the theme is, the message is the same from yesterday. Dr. Razi, one of our batchmates, he's an intensivist in Houston, Texas. He has kind of echoed what you have covered so far. The timing of the care and the timing of the intervention is very, very important, whether it's to do medication, when to intubate, when not to intubate. That's a crucial part in this COVID care regarding the sick patients. The timing is extremely important, that when you're going to intervene, when not going to intervene, that's going to decide the outcome of the patient. Thank you, Dr. Yadullah. Please carry on.
So the role of nitrous oxide doesn't do a great deal. So I wouldn't waste resources on giving nitrous oxide to this patient. And I haven't seen a huge difference. It may increase the hypoxia part, and if you look at the previous slide also, there are different big studies that have been done which have seen high PEEP versus low PEEP. What it has shown is that increasing the PEEP may help in improving the oxygenation, but it doesn't change the mortality. What it does is it prevents people from getting prone, from getting to rescue maneuvers and other things, but it doesn't change the outcome in the end, mortality. And probably it's a wrong question to ask as well. Does increasing PEEP change the mortality? Because mortality is not just dependent on PEEP in a patient who's got a multi-organ failure. So now looking at the remdesivir trial, what they say is that people who have received the remdesivir, the duration of the illness is shorter, but what they have done is they have taken out patients when they were doing calculations of the patients who didn't make or were sicker or died. And there is another issue with this is that it doesn't change the outcome as such. It doesn't change the mortality. So I don't prescribe remdesivir. I don't even say yes to patients who want to be trialed. So we are not trialing on this one. Now, there are other drugs that have been in there. One is Calatra. We have had a lot of experience in our center of using Calatra when the MERS-CoV was there. Now, again, the results up to now, what we have seen are not that heartening. Now, there is other antiretroviral called favipiravir, which has been used in Italy and other places. Again, initial results from what we are seeing, the people who are in trial settings, not that encouraging, but we need to wait for good, robust studies. So none of these drugs have come out and done any sort of huge, remarkable changes that we're going to say, okay, today we're going to take this up and it's going to change the face of the disease. Now, if you look at convalescent plasma, 48 hours ago, we had a study that was published which says that it doesn't change the outcome. Now, it doesn't change the outcome. Is it because we are not giving the convalescent plasma at the right time? Because they say that already all these sick patients have got pretty lots of antibodies in their own blood. What good are these antibodies? Are they effective? Are they taking care on fighting against the infection or not? So what we need to be wary is that we have got a patient who is going through a financial crisis of everything that's going around because of recession and this, what is happening with the pandemic. Added to that, his life is at risk. If he is the only breadwinner, things will change for the family. So what we offer needs to be really making difference. Now, the recovery trial that was done in steroids used in UK had shown that there is a mortality benefit. And I have shown this pathway, so I won't be going again what the inflammatory process happens in there. What the steroids do is that the steroids act at the level and decrease the production of cytokines, and they prevent the mobilization of leukocytes. And the inflammatory response is dampened down. So during the exudative and the proliferative phase, the response is blunted compared to what you see later on. So they are of benefit. Now there are concerns that would they be causing replication of the virus, and would they be making things worse? So what I would recommend is that we initially started by using methylprednisolone. So what we have, initially we started using methylprednisolone 40 milligrams BD. And what we realized is that these patients were running ridiculously high sugars, most of them. Some of them almost to the extent of decay, riding on very high levels of insulin infusions. To repeated testing of sugars, the nurses used to go in, so there's a risk of getting infection, how much preventive measures you take, and you put them on a long-acting apart from that. Now, do we really need that high dose? Answer probably is that very high dose may not be beneficial, but we will know when we have got robust other studies coming out. Probably 6 milligrams is what looks all right dose for now for 10 days. That's the initial phase when the steroids can make the best of differences. So that's where we see. And in the later phase, we have some centers, especially the expert specialist centers, using high dose methylprednisolone in combination, especially when there is a cytokine storm. And you need to treat that along with IL-1 inhibitors, anakinra, or IL-6 inhibitors, tocilizumab, be given. Again, the timing at which you give these drugs is very important. If you give these drugs too late, it's not helpful. And if you give these drugs too much, it causes immunosuppression and can cause increased mortality. Now, there are lots of trials that have been done. Some have shown benefit of steroids. Some have shown that steroids cause no benefit in ARDS. Now, the beauty of recovery trial is that ARDS is a conglomeration of different diseases, heterogeneous etiologies. But here in recovery trial, we are asking a question: is it helpful, beneficial in ARDS due to NCP, novel coronavirus pneumonia? So that's the beauty of the question. So it is addressing a disease here rather than a syndrome, which is a ghost diagnosis. So for now, it looks that the evidence is good, but it needs to be peer reviewed, and it should be replicable. So we'll know whether this result is replicated in other centers or not. So we'll know in coming days. I talked about cytokine storm, and we do COVID beds on admission, and then we do COVID beds in 72 hours. If things are not progressing well, we do it earlier. We check it in interleukin-6. Now, most of the centers don't get results back quickly. We check ferritin, and we check LDH, we check D-dimer, and if the ferritin is greater than 600, or if the doubling, LDH is raised more than 250, D-dimer is raised, don't just take this blood test. If you take the blood test numbers and go on and give tocilizumab, invariably everybody will get tocilizumab. You need to look at the clinical picture. You need to look at the patient. You need to see whether it's getting better or clinically getting worse. Are there indicators that are taking him in the right direction or wrong direction? Now, patients who are not going to be improving, what you have done is you have done sedation, you have done paralysis, you have done transient nitrous oxide, or may have not done it. They're not improving. Then you have looked at their compliance, and the compliance is sort of high. You put them on conventional ventilation and prone them. If the compliance is low, what you do is you try and see if they can have an APRV. Okay. Now, APRV can be used as a rescue instead of proning, or you can prone on APRV as well. So proning is the next thing. Now, patients do improve quite a few subset of population compared to the normal ARDS versus COVID reduced ARDS. Patients improve, their oxygenation improves when they're prone. And when you unprone them, it may deteriorate or it may not deteriorate. So that's something that needs to be highly considered. And patients, most of the time, when you're proning the patients, they are highly sedated and they are paralyzed with a cisatracurium infusion. You can give rock or a tracurium infusion. Cisatracurium has got the best evidence. Now, if they're not improving despite all this, you have done recruitment maneuvers, you've done sedation, you've done all the lung protective ventilatory strategies, you've done all the tricks in the book, they're not improving. And they are of the age limit, say somebody is less than 60, no comorbidities, very fit, nothing happening, nothing, single organ failure. You should always discuss every case with an Ecmo center or ECLS center, whether they would be candidate for VV Ecmo, and then these patients should be considered and they should be put on ECMO. Now, one of the things that I forgot to tell is that they should have a bedside echo, which is focused looking at the RV function, LV function. I don't want to go, there was a discussion yesterday about what the cardiological manifestations are. So I'm pretty sure that has been dealt with in the discussion. And you need a focus echo to look at what the pressures, is there any acute right-sided failure? Because if there is when I'm going to talk about in hemodynamic monitoring, which drug and what to use. Now, the map that you are aiming for is 65 and greater. So what happens is the blood comes from the veins, heart is just pumping the blood out, right side to the lungs, left side to the whole of the body, and you've got arteries. Now, if you have got dilated system, which accommodates 5 liters in a normal human being, it can accommodate 10 liters or 15 liters. So the patient's blood pressure will drop. So one is that they should replace the volume to begin with, of course. In ARDS patients, you are worried in giving volumes to see, oh, if I give a lot of volume, am I going to overload the patient? So there are clinical ways of checking it, not just looking at the JVP and other things. They're not very, very helpful until somebody's JVP is strongly up. What you can do is straight leg raising test. So you can attach them to a cardiac monitor, look at the stroke volume, raise the leg, both the legs up, and hold it and see what the stroke volume happens, if there's a rise in the stroke volume by 12%, what it means is that this patient is fluid deficient, so you can easily go ahead and give a fluid bolus. Now, we give 4 ml per kg bolus normally, and it's a crystalloid. And in Western countries, you go for Hartmann's or Ringer lactate compared to normal saline because of risk of hypochloremic acidosis. Now, you give them and fluid fill them optimally. If the person has got edema in the later stages, then you can give concentrate 20% albumin. Otherwise, the evidence is very low, level C, not very great deal of evidence. So cumulative positive fluid balance overall in sepsis is associated with mortality. Now, the second thing is that once you fluid fill them, you sometimes can do bedside monitoring to fluid fill them. You look at the IVC, if they're collapsing more than 50%, if they're not distended, you can look at the TAPC and MAPC. You can look at the SCVO2. If it's less than 70, indicates intravascular depletion. You can do a paired central venous CO2 from vein and an artery, from the CVP line and artery, and you can see the difference. If it is less than 0.8 kPa or 8 mmHg, then that suggests intravascular depletion. So you can look at the capillary refill time, you look at lactate. If it's greater than 2, indicates intravascular depletion indirectly, or there are other things that you can do, invasive monitoring. Now, in a pandemic situation where the resources are stretched, you may find it difficult to do this, and you may find it difficult even to do a bedside echo repeatedly because it predisposes you to exposure. You try to minimize that. But there are invasive hemodynamic monitoring techniques like using LETCO, which gives a pulse lithium dye, goes through the system. You just need an arterial line. You don't need a central line. It gives you stroke volume variation. It gives you what the cardiac index is. And depending on that, you can tweak that, whether you want to give an inotrope, something that contracts the heart, like dopamine, adrenaline. I agree with the comment that you have to be very cautious with the dopamine because it can give rise to arrhythmias. And the second thing is that if somebody's systemic vascular resistance is low, then it needs squeezing. So you may want to give norepinephrine if it goes to a 0.3
You have found
above, and then you want to add in a steroid to potentiate the effect of norepinephrine. You may add on vasopressin. Or if somebody has got a right-sided heart failure, then you may need to go for enoxamone or milrinone. So it depends on what is causing the decrease in cardiac. Are they deficient in fluids? Crystalloids. Give them only to fill them, don't make them positive balance. One thing that I have seen is that we have got fluid balance wrong even in the best of centers in this, and everybody agrees on to that. Because when the COVID patients come into the hospital, they come with a very bad X-ray, but they are intravascularly depleted. The reason is that some of them may have diarrhea, which is a symptom. Most of them have got very high temperatures, and they have got very high insensible losses. Normally you would lose 500 ml, but they may have a liter, 1.5 liter or more. And the work of breathing is very high, so you get insensible losses from that one as well. So you need to fluid optimize them. Don't make them positive. Even if you get them neutral, the 500 insensible loss that normally happens in the absence of temperature and other corroborative things will keep them slightly negative. So keep them slightly negative, but at the same time, don't run them too negative. Because one of the things that you will see is that if you keep them too negative, then that may impair the right ventricular output and may cause type 4 picture as well. So you have to be careful about that. So use it in a very judicious way. Now, don't use starches, please. No gelifusing and stuff like that. Now, coming to the first choice would be norepinephrine. I completely agree.
You have
any
4
center
minutes left.
Okay. These are pictures of various devices and what you can do. Now, just about PICO, if you have got a PICO monitor where you put an arterial line into the central one and you put a central line, you can even check pulmonary vascular permeability index. So if you have got extravascular lung water index that is raised, which will be raised in pulmonary edema and ARDS, PVPI will be normal in pulmonary edema, whereas in ARDS, it will be raised. So that's again helps to tell in ARDS patients. Now that's an echo, that's a video for 2 minutes. I'll skip that because of lack of time. Just briefly touching on AKI in COVID is usually multifactorial. And most of it is pre-renal from volume depletion. Drugs play an role because you may be giving nephrotoxic drugs that may be used to treat bacterial infection or other infections. then the virus itself can directly affect the kidney tubules. There could be microthrombi forming in there that can give rise to damage to the kidney, and there can be cardiorenal failure. Any of these things can play a role in that and can give rise to injury to the kidney. And people who end up on renal replacement therapy and a ventilator in a COVID-positive pneumonia, the chances of dying are 88%. That's a pretty high one. Now, there is a difference in incidence of the AKI that we have seen. It's probably got to do with the difference in the subset of population that they have taken, sick versus non-sick, and what they have seen, and the degree of AKI they had. Now, coming to the VTE prophylaxis, the UCL guidelines or the Hematological Society that has endorsed this, depending on the D-dimer values, we decide how much of low molecular weight heparin you're going to give to these patients, as they are very prothrombotic in there. So this, you can go through the slides at leisure when you have got. Now, cardiac involvement, I must say that if they have got a normal troponin, good outcome. They may come with slightly raised troponin that gets normal later on, but beware and be careful. Monitor the QTCs. They can go into tachyarrhythmias that are resistant to electrolyte corrections, and immunotherapy have to shock some of the patients. So keep a close eye, and if they're developing any changes and they need any intervention, act early. They are at increased thrombotic events and can have an MIs. Now, feeding in COVID, address to the nutritional status, physiotherapy and occupational therapy. I have seen patients presenting with nothing else but strokes, young patients with COVID. 2 of them presented with dense MCA infarcts that needed decompression. One of them survived, one of them died after decompression. Today, I've just seen a patient who presented with a dense stroke, luckily got thrombectomy done in time at the time of presentation. GCS 15, we are following it up. The beauty is that she has got a metallic aortic and mitral valve, and we are holding the anticoagulation, probably review and start it tomorrow morning. Delirium is an issue. It's a separate topic in itself. Use desmorobidine, clonidine, risperidone, or quetiapine and olanzapine. When you're using them, be careful you see the QTC. Common medical emergencies are still common in patients who have got COVID. So be mindful of them and take care of them and treat them. CPR is going to be discussed tomorrow, so I'm not going to go through the algorithm. These are the references that I've gone through. So if you want to go back and read through in detail, you can do this. And thank you very much for listening to the lecture and giving me this opportunity. And if you've got any questions, feel free to shoot.
Thank you very much, Dr. Yadullah, for managing to reach the end of the marathon. And it was a very monumental task to complete such a vast topic. And I'm quite pleased that you have done it extremely well, very elegantly, very professional. You have covered a lot of topics on hypoxics, LNH phenotypes, staircase management. You touched on role of PEEP in creating pneumothorax, recovery trial, and remdesivir, focused echo. I'm quite happy that you have included the echo in such a crucial thing in the management of fluid dynamics in ICU setup. And finally, last but not the least, on role of Ecmo and the cardiac manifestations. You kind of echo what I have presented yesterday. For half an hour, you managed to get it assimilated in one slide. Excellent. Thank you very much. I think I opened the panel for discussion.
So a few comments for juniors, basically for septic shock. Can I, Dr. Nurullah?
Yes, please go ahead, please.
Because juniors are facing the many cases of septic shock in ER. So how to assess? Basically, history is very important. Is it septic shock or cardiogenic shock? So there's a lot of confusion is there, what to do and how to proceed. So history is very important, of course. Once after taking history, suppose patient going in line with septic shock, then you have to look for some parameters that can support you. Clinical examination. Example, as Dr. Yadullah mentioned about the capillary refilling. So in septic shock, the hands should be warm. In cardiogenic shock, hands should be cold, because the basic pathology in septic shock is vasodilatation. So this can make a difference. So just examine the palm extremities. It will cold in cardiogenic shock. It can be warm in septic shock. It depends on severity. So severe BP is not recovered, of course, can be cold also in septic shock. But initially, at least it can make a difference by examining the palm, cold extremities in the cardiogenic shock and warm extremities, and also can have bonding pulse. Okay. Then look for the JVP. JVP will be raised in the cardiogenic shock and be flat in the septic shock. So these parameters will help you to guide for the differentiate between septic and cardiogenic shock bedside. Once you suspect septic shock, treatment of choice is IV fluids, because I have seen many patients in India, just they give 500 ml of saline and they start the ionotropes. No, because as discussed before, septic shock is depletion in the intravascular wall, so need IV fluids. IV fluid is our first treatment of choice. Second thing is, don't delay antibiotics. The most important thing is early antibodies have good prognosis in future. So in medicine, actually we know in three diseases, you give early antibiotics: meningitis, endocarditis, and septic shock. Please don't delay antibiotics for any reason. So try to give as early as early antibiotics to have a good prognosis in future. Thank you.
I think I echo what you have said. Like, it's very crucial to have a good clinical skills when you're assessing these patients. The bedside clinical skills, that's all you need to start with. And once you recognize this patient is septic, get a blood culture, get the antibiotics. First few minutes and few hours, not even hours, I would say, first hour is a golden hour to save these septic patients. And what the early intervention of diagnosis is extremely crucial to save this patient's life. Dr. Ayum Khadri, can I request you to share your experience, how you're managing the septic patients in the city at the moment?
Well, as this saline septic campaign give that management plan, the most important is early antibiotics. That's what makes the difference. Because every hour delay in giving appropriate antibiotic that will affect the mortality. It increases by 7% every hour that you delay giving appropriate antibiotic. And then the fluids, of course, like patient comes in with severe sepsis, or septic shock, you just have to resuscitate with adequate fluids and ionotropes. This is what has been described to help patients who comes with septic shock. And source control, the other thing which is very important is to do the source control. If you don't control the source and give whatever antibiotic or whatever durations and whatever you do, it's not going to help the patient.
And when are you introducing the steroid? What's your criteria for introducing steroids, and specifically for the current COVID patients? And what about the other medications like L6 antagonists, tocilizumab?
Yeah, steroids, basically it helps when in spite of all your resuscitation and the inotropic support is increasing, and then you introduce steroids, because most of these patients, they do develop adrenal suppression or insufficiencies, and you don't need to look for cortisol levels or all these things. And when you start steroids, it does help in reducing the inotropic support.
Okay, thank you. I just want to ask a question for Dr. Yadullah, if I may. What's the current role of Ecmo in these patients? You getting good results, and have you got any patients on Ecmo at your center? If not, what about Dr. Ubaid? I mean, do you have any Ecmo, if you are Ecmo centers?
So currently, we don't have anybody on Ecmo. They don't fit the selection criteria. That's the reason why they are not on Ecmo. But with proper treatment and proper selection, from what the initial data that I got from the GSCT and other centers, about 60 to 70% patients can survive when they're given treatment, but you have to do proper selection. Now, I would like to add two things which I've seen in my personal experience is that initially patients, when they present with COVID sepsis, they don't have any bacterial infection. So the role of antibiotics is only if your area is thinking of superadded secondary bacterial infection. It's down the line that they develop these secondary infections. And you have to be very careful, especially if you're giving drugs that suppress the immune system, then you have to think, especially tocilizumab and others, think in terms of fungal infection and be mindful, do galactoman and Senval and do HRCTs if need be, and then consider antifungal cover. In terms of giving steroids in septic shock, if somebody is requiring more than 0.3 micrograms per kg per minute of norepinephrine despite being free pill, then you can give them 200 milligrams of hydrocortisone and see if the MAP increases or the inotropic requirement drops down by 10% or 10 to 20% and see that there is a response to that. If that happens, either you can give 10 milligrams per hour infusion or you can give 50 QDS or 60 QDS of hydrocortisone. That's normally when there is a relative adrenal deficiency. But this has to be played in a way that you don't want them to be immunosuppressed. But the logic is that if you give steroids, steroid has got the second messenger as to produce proteins, make the production of the proteins through RNA, and then that increases the upgrades the receptors. So the adrenaline that is being produced becomes much more sensitive. So then the vasodilatation or vasopressia is there. The open control of inotropic requirements drop down.
Dr. Parvez, are there any centers in Hyderabad treating patients with Ecmo currently? I mean, there are quite a few big private centers over there. Anyone had any experience with ECMOs? If any of the patients need to avail the opportunity?
Yeah, there are quite a few centers in Hyderabad who have started using Ecmo, especially for COVID patients here. But as the panelists have been saying for the last 3 days, the selection of the patient is the most important thing, and the timing. Most of these patients does not fit the criteria for starting Ecmo with venous or arterial. They don't fit the criteria. They have a lot of complications with thrombosis and all. So, so far, I don't have any data locally in our hospitals that Ecmo has saved any life in Hyderabad.
For the benefit of our attendees, can you expand on Ecmo, just a simple basic, what Ecmo is, what does it involve, like full form?
It's a extracorporeal oxygenation. It's, for example, if we are all familiar with the dialysis, where the blood is transferred from out in the machine and then again come back in the circuit into the lung, into the body. Here, there are two types of Ecmo, venous and arterial. That is technically difficult to explain everything now. But basically what it does is it adds more oxygenation. Then the oxygenation is the primary problem. Ecmo helps to improve the oxygen in the lung to the blood better.
So it's like an artificial oxygenation outside the body.
Exactly.
You draw the blood, you oxygenate it and you infuse it.
Just a lung dialysis.
Yes, it's like a dialysis. Instead of cleaning the stuff, you're just infusing oxygen in it.
Yeah, in dialysis, you remove the blood, and the urea and the extra, the bad things. And in Ecmo, we add oxygen to the blood.
Okay. Dr. BC is providing active cover, isn't it? I've seen some patients with cardiac arrest and who would, put on Ecmo and during primary PCI, and they managed well over there. This was when I was there last year.
So when to start Kiletra? Kiletra, I'm not a fan of. I have not given it to anybody. Steroids, if somebody comes in to the hospital, they are requiring decent amount of oxygen. If they are on high flow or even more than 6 liters of oxygen, dexamethasone 6 milligrams will start if they are COVID positive. Now, in terms of tocilizumab, you would give it only if you think that there is a cytokine. If somebody is having all the biochemical markers and clinically they are starting to deteriorate in a big way, and they are pulling up an organ, going on to a ventilator. So if they meet the criteria, as I suggested, you should give them a dose of 4 milligrams per kg. Now, the NGHA guidelines and the guidelines suggest that you should repeat it in 12 hours. You have to be very careful about that. You should do it only if needed. Some people say after 3 days. Most of the patients do well with just one dose, single dose. If you over immunosuppress patient, down the line, you will be paying the price. They will get superadded bacterial and fungal infections, and that will be difficult to manage.
Okay, thank you. I have a question for the panel. I mean, anyone is open question for anyone who have experience managing pregnant women and children, especially lactating women with the COVID. I mean, we don't have a gynecologist in the panel, but if anyone is open to, because this is a recurrent question coming out from the attendees. Dr. Najib, anyone in the primary care, anyone who wants to answer this question?
Dr. Parvez can answer, inshallah.
Yes, please. And anyone, it's an open question.
Well, when we're treating the pregnant patients or lactating patients, if they have mild to moderate symptoms, they don't have to be treated with all drugs which are contraindicated, especially during the early and the late pregnancy. Lactation, some of the drugs are contraindicated, needs to be avoided. But if it is about saving life, there are no contraindications for any drug for saving life.
Yeah, so I think it's always important that during pregnancy, the mother's life take preference over the child's life. So when there is a when there is a debate regarding saving a mother's life or the child's life, infant. Right?
So when there's a pregnant patient, always look for the drug index to see if the category A, B, C are safe. D used to be used with caution. X needs to be should never be used during the pregnancy. So each drug has a category, the safety category. Always better to check for the safety category and then use it. A, B, C can be used judiciously and you can use liberally, but D should be used very judiciously during pregnancy. It should not be. It's completely contraindicated.
Well, in my setup, we had a few nurses who were pregnant and they got infected actually. So luckily, what happened was both of them really came out very well. So they only ended up having very mild symptoms. They only required very much symptomatic treatments and they really fared well. So I would rather look at these pregnancy and COVID in terms of trimesters. Well, if she has to the first trimester, depending upon the severity, probably we might be also contemplating abortion as well. If we were thinking of getting her, into the more serious kind of treatments, like tocilizumab, or if that is favipiravir or something of that kind. But if it is beyond the first trimester, it would go either ways. I mean, it depends upon how she fares well. But then, at this point in time, probably I don't have the answer to that question, how things would really go beyond the first trimester and the second trimester. I've only had the chance of looking at the people who were pregnant in the third trimester, a cluster of 3 nurses in our hospital who really did well and nothing happened. So, it's probably like what the panel has said. Probably a bigger gynecological center perhaps would really have a good and a better answer to that. But like what Dr. Parvez has said, we've got all categories of X and Ds that really should be avoided at any trimester for that matter. So
I think if you remember about Zika virus, I think a few years back we had a very nasty virus, Zika, especially in the Brazilian and South American countries, where the women were giving birth with children with anencephaly, no brains, and children were born with mentally retardation. And I think it's early days. I think because the pandemic has started just from last 3 months, and we'll have to wait for another 6 to 9 months and to see whether there's any effect on the long-term effect on the patients who got infected in the first trimester on organogenesis. We also are aware that children who have been infected with the COVID-19, they're coming with some sort of inflammatory arthritis. There have been multiple case reports, case series being published about the young children having after effect with inflammatory arthritis. Has anyone had any experience or read through any literature regarding this?
So if you look at the CDC guidelines, and if you look at the Royal College of Obstetrics guidelines, we are in a learning phase. First of all, we have to accept the fact that what we don't know, we have to say that we don't know. So if you take the classic example in the third trimester pregnancy, Mr. Boris Johnson was the Prime Minister, current Prime Minister. His partner was pregnant, and she gave birth to a healthy baby. Now, in terms of, if you go on the CDC website and see, when I last visited, they said that if you've got a mild disease and you don't have a viremia, there is no evidence to say that it's going to be transmitted via the breast milk. But you need to take the precautions because there is a risk of airborne transmission. So if you're taking hand washing, hand hygiene, cleaning the breast and wearing appropriate mask, we can do the breastfeeding. Now, how much that is true? Because our knowledge has evolved from day one up till now tremendously. Initially, we thought that the virus is going to survive for 2 hours, 6 hours. Then later we realized that it can survive for days. There was a debate about aerosol transmission, how far we do need to do distancing, how far do we don't need to do distancing. Initially, people were walking without any surgical mask, even if they're not in contact. People were not wearing N95. We have changed to N95. Everybody is wearing a surgical mask now. Everybody going out into the community is wearing a mask. So our knowledge is evolving. So whatever statement we give with a serious limitation that this may change in future when we learn more about the disease.
So any other panelists?
I have a serious concern the way things are practiced in Hyderabad currently, that these pregnant patients are put to unnecessary testings like CT scans. They're exposed to high radiation in the last trimester, first trimester. Time will tell what are the major defects with the child when they are born. The unborn child have to face are bombarded with a high dose radiation, unnecessary CT scans, and the polypharmacy. Lots of drugs which are totally contraindicated during pregnancy are given to mild to moderate symptom patients with like ivermectin, colchicine. I mean, we can the polypharmacy and the CT scan may have a bad outcomes to the patient, unborn babies.
Yes, exactly. I think it's an evolving specialty, especially with this pregnancy, lactation, children, infection, long-term effects. One more question I have for the panel is regarding the serine protease inhibitors, especially that S protein which goes and attached to the ACE2 receptors. We have started using it in UAE instead of hydroxychloroquine. So we have swapped over. So we stopped hydroxychloroquine and we have moved on to the serine protease inhibitors. So has anyone got any experience? Because we just started it recently last week, and just want to get a idea from the panel that have you had any experience using it and any side effects profile, anything you want to share with us and the rest of the group? I think it's used. I'll just tell you briefly about it. It says 200 milligrams, 2 tablets 3 times a day. And these tablets were previously used for HIV and AIDS. And they had some encouraging results in SARS and MERS patients. So that's why they extrapolated that and trying to use it. Although there is no randomized control trial about it. There's a lot of ongoing trials with this, but this is just anecdotal evidence. It's a very cheap drug. Apparently, it's a very cheap drug as well. So that's another reason why this acceptance is slowly picking up in UAE.
This HCQ was being used as prophylactic agent also. Does this, the one you are mentioning about, it can be used as a prophylaxis also? Or
Yes.
only therapeutic?
I mean, there's no clear-cut guidelines on when to use it, when not to use it, but we are using it in the patients who are mild symptoms and who get admitted to the hospital. They stay in for a few days, get the oxygen levels monitored, and they get discharged from here. That's what we are doing in our government hospitals in Abu Dhabi at the moment.
Regarding the recovery trial, Dr. Yadullah has clearly stated about the role of dexamethasone to be started only in hypoxemic patient, but here in Hyderabad, the experience is that everybody with or without symptoms, mild, moderate, severe, everybody gets yours. No matter how much, I mean, even though we emphasize so much that mild patient does not require the treatment, we are treating the psychology more than treating the disease. There are the polypharmacy at its peak because of the patient and the doctors. They don't know exactly in which direction they're going. I was surprised to hear from a senior radiologist yesterday that he was found to have, he was positive, mild symptoms, and one of the consultants prescribed him remdesivir for a mild symptom. Dr. Yadullah may be surprised, and he doesn't give it to severe cases. And this patient, this person with mild having saturation of 98%, just the advice was just in case to prevent the cytokine storm, just in case to prevent cytokine, start dexamethasone, start methylprednisolone, start azithromycin, ivermectin, colchicine, and so on.
I think why don't they throw some multivitamins and PPIs and just for the sake of completion?
Yeah, we also have some Dindatilismart too.
There are a lot of they use a lot of multivitamins as well, vitamin C, multivitamins, vitamin D. Now, what I have noticed is that I check vitamin D in all my patients, and I have found that 85% are vitamin D deficient. Now, I'm replacing them, but whether it makes any difference, it's very doubtful, and it's going to be very debatable. I don't think these things are going to be the game changers.
Well,
vitamin D angle came with inflammation. I mean, this is how this theory of vitamin D and COVID-19, the link started going through what reduces the inflammation.
I've seen 85% people to be having low vitamin D. But having said that, we're replacing, but indiscriminately giving blindly without checking levels, I don't think it's advisable. Either folic acid or anything of any sort. If you're giving something like water-soluble vitamin C, it may not harm you, or B1, it may not harm you. But if you're giving something fat-soluble, then it's not a good thing.
I think people are latching on to any simple new drug, anything which is coming out. I've seen on the University of WhatsApp people sharing something like Kada or something. So I think common man is just latching on anything which he feels that is going to make a difference, without any scientific evidence. People claiming that some berry juice from somewhere in South America can cure of even a major disease. So I think people are desperate. That's the thing, and people are.
Medicine as an industry is at its worst phase and worst color. And medicine as a humanitarian field is also at its best shape. So you have got very good examples, great examples, people are doing great things. At the same time, you've got really horrible examples as well. But I'm very pleased that the good examples are much more compared to these ones.
Just read an article just yesterday. It will be probably published later, probably the next few weeks. That is the only study I have come across so far, which has showed that convalescent plasma therapy may benefit if it is given before intubation. If it is given after intubation, it has no benefit. So at the timing of the plasma therapy, if it is at the patient having moderate to severe disease, pre-intubation was shown to benefit rather than patient already on a ventilator. And apart from this study, I don't have any other study which, especially the studies which has come were published from China, Wuhan, I said that there was no benefit of plasma therapy.
Most of these patients, if you actually check antibodies, they have got a very high antibody levels who have got organ failure. And giving them further antibodies doesn't help. That's what the paper suggested, published 48 hours ago. And even in the less sicker patients who are progressing to organ failure, it is to be studied. Now, we are recruiting patients. We are giving 1 unit a day over 5 days and seeing, but the results will tell in future. It's debatable. Most of the colleagues of mine are really doubtful and skeptical about what role these antibodies have got. Are they strong enough to prevent organ failure? Are they strong enough to prevent people from getting sicker? We don't know. I don't know.
Just one more question to the panel. One of the attendees have raised a question regarding the recent relationship of PPIs and tipping into a severe disease. Has anyone got any experience that have come across through an article regarding this topic? Relationship of PPI and tipping from moderate to severe disease. Okay. Fine.
What is that question?
Sorry, Dr. Obed.
Yeah, what is the question?
The question is about the relationship between proton pump inhibitor and going into progressing into severe disease.
Yeah.
Currently, there's data out there.
and Dr. Yadullah, Dr. Parvez knows about this issue. PPI should be avoided, basically, patients on those on ICU and mental settings, because it will cause microaspirations. In general, PPI should be avoided patients who are on mental ventilators because it can cause microaspiration and can cause worsen the condition. So this is a basic guidance for the patient on the ventilators. Dr. Yadullah, can you come in?
So in terms of patients who are at high risk for forming ulcers, when patients get intubated, the first circulation that gets compromised in a patient who is in shock or multiple failure is the splanchnic circulation. So the gut mucosa doesn't get good vascular supply. The second thing is that people who are unwell get stress ulcers. These patients now, after the recovery trial, everybody is going to be dumped onto dexamethasone. So that again increases the risk of them having increased risk of having the ulcers. I haven't seen any upper GIP. But patients who are intubated, who have got especially renal impairment or platelet dysfunction, we in ITU as a practice, as a bundle, put them on a PPI.
Yeah, I think PPI is an essential component of sepsis bundle. That's how traditional PPI has been from last 20 years.
How about famotidine? Actually, there has been recently, some hush-hush about using famotidine. Actually.
Yeah, because ranitidine was had a bad name recently, so famotidine took a higher place. But famotidine has been in use for last several decades. It's one of the safest medicine. It can be used once a day instead of twice a day, as in ranitidine. It's one of the safest H2 blocker, which you can have, which can suppress enough acid for a patient who are not on steroids, a patient who has less risk of getting stress ulcers.
Yes. Question for Dr. Yadullah. For some reason, if tocilizumab cannot be given for a patient who has been assessed to have cytokine storm and already has developed some renal failure also, how much hemodialysis or some filters can be used which can filter out the cytokine?
So there is something called cytosol, which is similar to dialysis filter. It can be attached to a dialysis machine. And this has been extensively used and evaluated in patients with sepsis. There is a separate machine similar to dialysis machine that you can run that on. The results of this are not that encouraging, and it doesn't change the mortality. The concept looks very amazing. I haven't seen studies of cytokine use in patients with cytokine storm in COVID that have been published, or I'm not aware of any such significant studies. So the current moment of time, there is no evidence to suggest the use of cytosol. Now, coming to the second point of dialysis, now sometimes you can run them on filter. You can add 2 filters and run them on the same machine, but that's something that's not practiced and not advised. You can do high filtration, sort of high dose dialysis, instead of going in for the routine 20 ml per kg or 25 ml per kg. You can go up very high to 60, 90 maximum. But again, that has not been recommended. It doesn't give any mortality benefits. The biggest headache that everybody is encountering, and most of the patients are encountering, is that circuits are clotting despite anticoagulating the filter. So most of the centers, they are not able to do CRRT, and and strain on the system. They are not able to, they don't have that many machines to dialyze that many number of patients or put them on CRRT. So people are moving away in certain subset, not in everybody. Not everybody can have these modalities, like people are trying to do SLED, the sustained low efficiency dialysis or PERT, that instead of giving it for 4 hours, you're giving it for extended period of 6 to 8 hours, and trying to remove the fluid in anuric patients so they don't go into positive fluid balance and get overload of the lungs, get mucked up. And at the same time, hemodynamically, they don't sustain much instability. Just doing plain dialysis can be challenging. So these are the things that we are doing. Certain centers have plotted the filter circuit as well as systemic anticoagulation. But there's not much, it's anecdotal, still there. You anticoagulate the patient with therapeutic dose of heparin infusion, when that's happening. And most of the patients with severe ARDS, if they are having that, one of the things that you would do is to see if they've got DVTs or Ps. They may have no DVT or P, but still can have microthrombi, and they are put on anticoagulation in certain centers. Now, is that a gold standard? Is there any evidence to back up? No robust evidence to back up, but few centers are doing that.
To emphasize one last point, so today's session by Dr. Yadullah was completely evidence-based. We in Hyderabad try to follow, we do read guidelines, but we hardly apply them on our patients. We try to treat everybody in the same boat. We treat mild, moderate, severe symptoms. The cases are just like one. We are afraid of losing patients, but we are not looking at the long-term consequences of unnecessary treatment, unnecessary using money, spending money on hospital beds, unnecessary using high oxygen on patient who does not require oxygen, treating everybody with remdesivir, tocilizumab, getting high-end investigations like interleukins, and we don't know what to do with those labs. Getting treating asymptomatic patients. So my emphasis is please focus on evidence-based medicine, which is in the best interest of the patient. We cannot save all lives. Finally, the destiny is all written, but we are over-treating our patients and getting more investigations than needed. Thank you.
Yeah, just same thing, Kadi, because now, because almost we are closing towards our program next tomorrow, inshallah. So our audience should learn to avoid polypharmacy. At least from this conference, this program, try to learn avoid polypharmacy. As we discussed yesterday, please do more good and less harm to the patient. As polypharmacy, because COVID is a viral disease, so it can be the patient may improve without any treatment. We have seen, I've seen maybe 40% of my patients, they improve without any treatment. So why to give all the medication, polypharmacy medication? And as I told you before, liver is a chemical factory. Whatever you give medication goes to liver. So already liver is compromised, unnecessary causing burden to liver. So please learn not avoid polypharmacy. Be logistic. What to give what time? This is very important. Message from the Dr. Yadullah and Dr. Parvez. Please, the message should be here from the conference. Please avoid polypharmacy. Second message, now from today, at least try to think of important guidelines, please. Don't give the treatment what is not required. I was surprised Dr. Yadullah. In bronchitis patient, using Montelukast. But Montelukast is used as an anti-allergic medication for every upper respiratory tract infections. I am surprised. From where they got this? Yeah, Dr. Parvez, Montelukast, every patient is getting Montelukast. Wallahi, is surprised. So one message from I got from a colleague in USA. There was a debate between the one Indo-American doctor and Indian doctors. So they say, we Americans, we read Harrison and practice. You read Harrison and don't practice Harrison. So please, especially juniors, try to learn from this. Go for guidelines, because in future, guidelines will support you. Medically, the things people are becoming smart. They may go for, they can show you. Consumer code will support only by medical guidelines. Otherwise, you'll be in trouble. So please, from all the juniors, try to learn this. Follow the guidelines. Look for the guidelines. Don't give polymedicine. I learned from my professor, Dr. Muhammad Azam. Maybe people know this. Wallahi, Allah Rahma. He already, he was a good, genuine, genius professor of the era. He told, any medicine you want to give, you can give a patient 2 medicines. Third medicine you want to give, please think twice. Really indicated? What is the indication? What is the dose? And what is the complication? So this is a good physician practice. Otherwise, if you give polypharmacy, wallahi, I just tell you, you may not get patient in future, because doctor is judged by doctor. I know Dr. Parvez is giving less medication. I'll send those patients to him, not to the other doctors giving polypharmacy. So make a practice from it now. Don't go with the practice of the other physicians or medication. Come. Next patient comes, okay, this doctor is good doctor, please give less medication. Please try to learn message, give less medication. Every medicine you want to give, why I'm giving, what is the indication, and what is the complication, and what is the interaction with other drugs. because this can kill the patient. Please remember, message should be from this our conference. Thank you so much.
Thank you, Dr. Obey. Thanks for emphasizing the basic role of a doctor is to do no harm. Do no harm. The more medicines you put, the more harm you're causing to the patients, because these patients already have a lot of comorbidities, and you add on more medications, and it's going to create more havoc inside the bodies. Thank you very much, everyone, for joining us today. And we have covered very important topics of sepsis, respiratory failure, and guidelines. It's been a very productive day. We have been enlightened by presence of Dr. Parvez and Dr. Yadullah. Thank you very much.